Hi, this is Julie Levinsky. I'm the Associate Director of Digital for the Christopher and Dana Reeve Foundation, and I'd like to welcome you all to this month's live web chat with Nurse Linda. I'd like to tell you a little bit about her. She is a leader and provider of rehabilitation nursing for over 30 years and a friend of the Christopher and Dana Reeve Foundation for close to 2 decades. She is on our online community where she writes about and answers your spinal cord injury related healthcare questions in our health and wellness discussion. So now I'd like to turn it over to Linda. Hi, Linda.
Hi, Julie, and thank you everyone for joining us today. I wanted to just bring to your attention, it seems like every day of the year is a day that is celebrating something or bringing our awareness of an issue to the forefront. And May 5th is National Mental Health Day. So I thought that would be a great thing to start with today because I know that sometimes when you have such a huge life-altering change in such as spinal cord injury or any of the other chronic illnesses that result in spinal cord injury, that it can certainly be a trying time. So if you think you might be hitting a rough patch in your life, if you're having trouble adjusting to disability or you're just having trouble with any point in your life, really, be sure and talk to your healthcare professional. They can screen you right there in their office at your visit. You might even want to be screened every single time you go to your doctor just to make sure that you're on the right page. And they have a little screening. They can ask you a few questions. If they think there is a problem or you think that there's a problem with your mental health, then be sure and ask for assistance. There are a lot of people you can talk to. There are certainly groups that you can participate in. There are therapists you can go to. But remember that there's a lot of talk about depression. Depression is a physical problem, just like a spinal cord injury is a physical problem. Depression is a physical problem. It's a change of chemicals in your brain. And it's not something that you can just tough it out. It's not something that you can, just try to do better and it will resolve. Once you have depression, there are some medications that you can take to even out that chemical balance in your brain and help make you better. So you don't need to suffer in silence. You don't need to try to, power through it or think that you're alone in these things. So be sure and check on your mental health. Sometimes when we're living our day-to-day life, we don't realize how things have kind of piled up on us, and it happens before we even are aware that, I really kind of just had it with everything. So be sure and check with your healthcare professional so that you can assess to see if your mental health is where it needs to be. Now, certainly there are days that we get blue. There are days that we all have rough days, things that just pile up on us, and the next day things are better. So, depression goes on for quite some time, and sometimes it becomes so normal to us we don't recognize that we're in the middle of a depression. So everybody is susceptible to it. It's not any defect in your personality or your being. It's just that sometimes the chemicals in our brain just get a little off kilter. Another thing I wanted to alert you to is the See Me campaign that the Reeve Foundation has started. This is a campaign to help people actually see and view people as all people as people instead of viewing somebody as their disability. So that might be something you might want to participate in. It looks like a wonderful campaign. And I know that from reading on the community's website, on the Christopher and Dana Reeve Foundation website, I just find a lot of interesting people who've had spinal cord injury either from trauma or from medical problems. And they kind of put themselves out there, really, is what they do, and talk about the issues that they've had. And when you read some of these stories, you really think, oh my gosh, you can immediately see, well, I'm kind of having that. And then other people will react. So you get a bunch of different ideas about how to deal with different situations. And this is really helpful. It's just, if you get on the communities, you'll just find that it's just fabulous, and everybody there is so encouraging. So this month I've been working on what we call in healthcare comorbidities. They're problems that often occur with spinal cord injury. So, spinal cord injury, a lot of times people think, well, I know that's all about people who've had trauma, but it's not. It's people who have medical issues that cause spinal cord injury as well. And so sometimes people don't think there are that many people out there with those kind of issues, because if somebody has spinal cord injury from, say, multiple sclerosis, they don't necessarily identify themselves as having a spinal cord injury. They would identify with a group that has multiple sclerosis. A complication of multiple sclerosis can be spinal cord injury. So it's kind of down the line, but it's the same issues. And it's the same problems. It's the physical manifestations of the MS is usually more spinal cord injury symptoms. So there's a lot more people with spinal cord injury from medical problems than there are from people from trauma. But, people just don't think of that first, because they think, oh, I have this disease, and that is what I have. But some of the consequences of that disease also are spinal cord injury. So be aware that when we talk about spinal cord injury, we're talking about the whole gamut, and we don't care how it got there. We just know it's there, and now we're going to deal with it. So one of the things that I have been talking about is stroke on the blogs this month is stroke. So there's two ways that people can have a stroke. One is in the central nervous system, and everybody's familiar when you have a stroke in your brain. You might have some paralysis, visual problems. Maybe you might have speaking problems, depending on which side of the brain the stroke is on. But there's some very definite symptoms. Well, people can get stroke in their brains, but they can get a stroke anywhere in their central nervous system, which is the brain and the spinal cord. So sometimes people have a stroke actually in their spinal cord and not in their brain. And so what they have then is a spinal cord injury because they had a stroke, but in their spinal cord. So, and that can happen to people at any age, just as stroke can. People often think, oh, I'm not old enough, I couldn't be having a stroke. But in fact, you can be having a stroke at any age. Working in the spinal cord injury branch of healthcare, I've seen stroke in individuals of all ages. I've seen stroke in teenagers. I've seen stroke in newborn babies that are born and have a stroke in their spinal cord or in their brain. So it can happen to anyone. It doesn't happen a lot, fortunately, but when it hits you, you certainly notice this. So if you feel like you're having any kind of weakness or tightness around your waist or any kind of problems in movement in your body, think about that you could be having a stroke in your spinal cord. So, these are not things to really linger on. If you have a stroke in your brain, people will usually notice those symptoms right away. That there's a mnemonic called FAST. So you might see in your face, you might see one eye drooping or one side of your face drooping, the side of your mouth drooping. So if you look at asymmetry or your face not being equal on both sides, that's certainly a symptom. And then the A is, again, looking at the asymmetry throughout your body. So if you're not able to use one side of your body or even just one leg or one arm. And then the rest has to do with getting treatment right away, because if you have a stroke in your brain, there's medication that you can take, but it must be delivered within 6 hours of your symptoms of the stroke starting to really be effective. So they have stroke centers around the United States, and if the ambulance people see that you're having a stroke, they'll probably take you to a special designated stroke center where this treatment all just flows. They have a plan for somebody who comes in the door, they have a stroke. This plan just gets enacted, and they get this clot-busting medication. So 70% of stroke is from clots, and the other about 15% is from hemorrhage or a blood vessel that bursts, and the other 5 to 10% is just kind of, oddity kinds of things. But anyway, so if you have this a stroke in your brain, you can get the clot-busting medication. Now, if you have a stroke in your spine, they've tried the clot-busting medication to see if that can break up the stroke in your spine if it's from a clot that's stopping blood from perfusing in your spine. But they found that that's not really been effective. So there's not that much opportunity for, if you have a stroke in your spine, to resolve the symptoms as there is if you have one in the brain. But it's still important to get treatment right away so that you can get medication to stop swelling in your spine and to avoid some of the complications and long-term paralysis. If there is a hemorrhage, maybe surgery might be performed to remove some of the excess blood to save the tissue that is still healthy. So that's one way to have a stroke in your spine. Another way to have a stroke is if you have autonomic dysreflexia, and we talk a lot about this. And so this is a complication of spinal cord injury that people have, usually if they have spinal cord injury in the cervical or neck area or thoracic, the back area, the part of the bony vertebrae that have ribs attached is the thoracic area. And usually it's at that thoracic level of T6 or above. We say that's when people are susceptible to autonomic dysreflexia. But it's recorded now much lower in the spine. So people as low as T10 have had episodes of autonomic dysreflexia. It's often called AD for short. And what it is that people usually get a bounding headache, and that is a symptom that everybody knows, but there's a lot of other symptoms too. If you have any of the symptoms, you need to take your blood pressure. So you need to know what your usual average blood pressure is. After spinal cord injury, your blood pressure tends to fall slowly over time. So people with spinal cord injury usually have a very low blood pressure. So if their blood pressure goes up by 20 to 40 points so if it goes up by 20 or 40 points in the top number, you're probably having an episode of autonomic dysreflexia. So everybody knows the pounding headache being one, but there's also other symptoms, and sometimes people don't have the pounding headache, and they'll say to me, oh, I don't have a pounding headache, so I don't have that, but I get goosebumps. Well, that's another symptom. Or they might say, I feel just like creepy crawlies on me. That's another symptom. Blurred vision, stuffy nose. These are all symptoms that you can have, and you might have one of them, you might have all of them. The way that AD is treated short term is if your blood pressure goes up, you are at risk of stroke in your brain. So you don't want to have a spinal cord injury, get autonomic dysreflexia, and then ignore the elevated blood pressure and then have a stroke on top of your spinal cord injury. So the way we treat it in the acute phase is if somebody feels like they're having autonomic dysreflexia, we sit the person bolt upright. And as you know, if you have a spinal cord injury, sometimes when you sit upright too fast, your body doesn't accommodate as quickly, and so it drops your blood pressure. And so we sit people up to take advantage of this orthostatic hypotension, which is that quick drop in blood pressure, and then that quickly lowers your blood pressure. Then we look for whatever the source of the problem is, and it's usually something that's bothering your body below the level of your spinal cord. So your body still works below the level of your spinal cord. You're just not getting those messages in your brain. But if your catheter's kinked or you have a bowel impaction, you have a pressure injury, even if you have a wrinkled sheet that you're sitting on, your body says, whoa, this is uncomfortable, I don't like this. That area will immediately start sending messages to your brain, but it can't get through that area of the spinal cord. Those nerves just start going kind of wild, and they just try to send a message any way it can from one nerve to another nerve to another nerve. So by the time something gets to your brain, it's like, wait a minute, something's wrong. Your autonomic nervous system says something's wrong, and it releases all the powers that it has to correct this. And that's why you have this blood pressure with all this blood pressure pumping because your body's trying to fix something, but it doesn't know what it is that's wrong. So anyway, that's a problem with stroke. You can have a stroke in your spine, or you can even have a stroke after you have a spinal cord injury, as in a regular stroke in your brain, or you can get a stroke from AD. So there is a wallet card that's available on the foundation website for AD. There's several wallet cards. You can put them in your wallet. They're trifolds. If you go to the emergency room or your doctor, you can pull out the wallet card for autonomic dysreflexia and say, this is what I think I'm having, and give it to the person in the emergency room. Some people live in areas where there are not many people who have spinal cord injury. Oftentimes people go to the emergency room and maybe the healthcare professionals learned about spinal cord injury back in school, but they've not seen anybody or dealt with it since then. So if you can provide one of these wallet cards that explains what it is, there's a special message to the healthcare professional, the physician, the nurse who's taking care of you. And then there's also references to scientific articles that they can pull up and read if they want more information. So it's kind of a very harmless way of saying, look, I think I have this, and let me show you this wallet card. And it kind of breaks the ice of, oh, yeah, well, maybe I heard about this in medical school, or I seem to recall this, but it's kind of foggy because I haven't dealt with this for so long. So it's just kind of a nice little ease into that, getting that kind of treatment. Another thing that I wrote about this month is skin care is always such an issue, and people kind of ignore that because they think, well, I'm on a cushion, so I don't need to do my pressure releases. But there is no cushion that can guarantee you'll not get a skin breakdown. And you can go for years and years and not have a skin breakdown, but, you know, our bodies all are aging as we go. Cushions get worn out before we actually realize that they're worn out. And so sometimes people get a pressure injury or a wound in their skin because they haven't been doing their pressure releases, or maybe they haven't been eating right, or whatever. There's always a variety of reasons why pressure injuries happen. Sometimes they happen not through anybody's fault. Sometimes they just happen because of normal aging and whatever. So it's just something we wanted to alert people's attention to. If you have a pressure area, say on your bottom or on your hip, on your shoulder, your elbow, usually people will get treatment for that. Treating pressure injuries are very expensive. So sometimes if people have a pressure injury on their foot or heel or their legs, or even on their hands. I mentioned elbow before. If it's a pressure injury on the extremity, sometimes your payer will look at that and say, gosh, it's a pretty bad pressure injury. We could spend a lot of money on surgery. We could spend months or even years on wound care. So we're just going to recommend amputation. Well, nobody's really interested in having their body distorted in that way unless it's absolutely necessary. So always be sure and ask for a second opinion. If you do not want to have your foot amputated, you do not have to have it amputated. You can refuse and say, no, I'd like conservative management of this. Now, if your foot has gangrene, that has to be tended to. That does require surgery. But sometimes it just takes a long time to heal up these wounds. Sometimes people don't know that they can ask for a wound care specialist to be looking at their wound. There's different devices and pieces of equipment that might be able to help your wound heal faster. The important thing is the only way you're going to heal a pressure injury of any kind is to stay off of it. So if you do have a wound on your bottom, and you think, well, I just need to get up and brush my teeth, so I need to sit in my chair for a while, or I need to go to work, so I'll need to be sitting, and then I'll be off of it the rest of the day. That won't work. You have to be off of it completely. If you have surgery, you will have to be off of it, because if you sit on that area, it's going to break right open again, causing oodles more problems. So just so you know that if somebody says, well, you've got a pressure injury, we'll have to take off that foot, think about if you want that to be done or not. It's your choice to have that or not have that done. And then see what you need to do about it. So if you look at your equipment, maybe your body has changed over time. Maybe the equipment that you originally had is not serving your new body habitus, as changes may occur because we all get older. Every day we're all getting older. That sounds a little depressing, but it's true. So look at your equipment. Make sure just at any point in time when you go for your annual checkup, make sure you look at the equipment too. I know payers won't pay for new equipment every year, and you don't need new equipment every single year, but sometimes there might be a change, or you might want to look at how your equipment is wearing and make sure it's still being effective. So let's go ahead and answer some questions. We've got some interesting questions in the chat box today, so I want to be sure and get to them all. So the first question is, what are causes of lower back pain after SCI? Well, that could be a variety of things. So first of all, it depends on where your spinal cord injury is. So people who have lower level injuries, wherever your injury is, the muscles above the injury that are working will have to compensate for the muscles below the injury that are not getting the message to contract or relax with your movements. So if you have a lower level injury, what will often happen is you'll sometimes get low back pain because those muscles right above that area of injury are having to overdo what they normally do because they're compensating for those muscles right below that are not responding to brain signals. So that can be one thing. Lower back pain also is a common symptom for kidney stones. So your kidneys are in your lower back, but not down in that little scoop in the lower back. They're above that. But sometimes that can radiate to lower back pain. Sometimes if you have a urinary tract infection, you might not be able to, those signals might not get from the bladder to the brain to say I'm having pain in my bladder when I'm urinating, or it's overstretching, or even if your bowel is impacted or overfilled, those messages might not transfer to the brain in the normal route. And so sometimes there's a thing called referred pain, and that can be in the lower back. Sometimes, you've heard of people who've had heart attacks, and that one of the symptoms of a heart attack is left shoulder pain or left arm pain. That is referred pain. It's the pain doesn't come in the heart area. It's referred over to the shoulder. So sometimes people who have spinal cord injury will have referred pain from something that's bothering their body below the level of the spinal cord injury. That referred pain could come out in the lower back. It could come out in the shoulders. Sometimes if you have sensation in your jaw, sometimes it will be a pain in the jaw. So that lower back pain could be referred from anything in the abdomen or the gut. And then the other thing is, too, is that you could have lower back pain just from overusing the muscles. So if you're reaching for things, because sometimes it's easier just to reach a little farther than to move your chair closer, we all tend to overdo our back. Sometimes if you're throwing your legs around, sometimes people will pick up their leg and just kind of throw it over on the bed. And I always kind of think, oh, wait, it's still your leg. And your leg still will get bruised or can have a broken bone. Your body is still working below that level of injury. You're just not sensing when your leg hits up against something, but it will still bruise if you did something. So if you're not careful with your limbs, it can get pretty sore. Those muscles are still all connected in there. So if you're picking up your legs and kind of throwing them over on the bed, or transferring and just kind of dragging them along instead of picking them up and moving them with you, sometimes you can get lower back pain because of the way the muscles all interweave together, and so the weight of that leg pulling on your body, if you're not picking it up and moving it carefully, can really cause some lower back pain. So just about anything that causes lower back pain for anybody can cause lower back pain and spinal cord injury. But also remember about referred pain, and also think about being careful with your body and treating it kindly. Even though, people say, well, I don't feel it anyway, but your body still feels it. It's still responding to it. So be very careful with those limbs. Some people will get, because they're throwing their legs around, they might be getting blood clots or abrasions. They might be having all kinds of problems with their legs. If you are having any kind of problem in your gut, sometimes it comes out as that referred pain. So there's a whole bunch of reasons. There's one other thing too. If you have a spinal fusion, sometimes, the vertebrae all work independently of each other to provide these movements that we all have when we twist our body, or when we bend over, or when we lay back. The vertebrae all move independently. When you have a spinal fusion, there will be one or two or three or maybe even more vertebrae that are held together by rods. So they're not moving independently. They're moving as a unit. Sometimes if you have a spinal fusion in your lower back, the vertebrae above or below that spinal fusion can create lower back pain, because those vertebrae above the fused ones are now having to move a little bit more. Sometimes if you have a spinal fusion in your upper back or in your neck, the same thing happens, and people will get some pain above the spinal fusion. Now, they probably also have the same problem below the spinal fusion, but they're not feeling that area. So when you have a spinal fusion above and below, sometimes that can cause that pain. Next question, will getting off gabapentin and going to Lyrica guarantee I'll be pain-free? Oh, if I could only say yes to that, I would just love to say yes, and then we would, then everybody would be doing it, I guess. All the kids, all the popular kids would be doing it, as they say. But anyway, so gabapentin and Lyrica are two different formulations. They're both medications that are specifically formulated to treat nerve pain. So if you have nerve pain, as in neuropathic pain, these drugs, in theory, should help you. Now, if you have muscular pain, like if you have the low back pain from overuse of your muscles, these medications won't help you so much. Narcotics do not help nerve pain. Gabapentin, Lyrica do. There are some other medications, antidepressants and anticonvulsants, so anti-seizure medication, taken in very small amounts, seem to help neuropathic pain. So there are certain medications that do help neuropathic pain, and the others really don't do anything. So a lot of times people will get prescribed for them opioids or narcotics, and they get addicted to these because they're taking them for their neuropathic pain. They won't treat neuropathic pain. They don't treat nerve pain. And so you're just taking these medications, forming this addiction. So don't stop them. Don't ever stop any medication like opioids, narcotics, or even these nerve pain medications, because you will be sent right into withdrawals, and then getting on top of neuropathic pain after that is even more difficult. These drugs all have to be tapered off, so don't just stop them. Talk to your healthcare professional and say, I don't believe that this opioid is helping my neuropathic pain. I would like to get off of it, and they'll give you instructions on how to get off of it so your body doesn't go into withdrawals. Very important. Same thing for gabapentin and Lyrica. You have to be tapered off these drugs. So if you're on gabapentin, you have to be tapered off the gabapentin, and before you can go on to the Lyrica, and then you have to ramp on the Lyrica. So you'll be a short period of time when you'll be on little to no medication before you can be on the next medication. So that's a very important thing to know. Now, some people, when they go off some of their nerve pain medication, they've been on it for years, they might notice that the nerve pain is gone. Nerve pain will resolve over a lengthy period of time, and it's different for everybody, and it's not like everybody's going to have this, it's not like, I wait a couple of years and it'll just be gone, because nerve pain changes as our bodies change and as we age, and it just has a way of liking to find a way to stick with people. So these two drugs work in different ways. Some people respond very well to gabapentin. Other people find Lyrica to be helpful. It's certainly, if you're not having good success with gabapentin, it's a good thing to try something else. Again, you'll have to have that tapering off period of the gabapentin before you get starting in on the Lyrica. Some people are very good on one drug for years, and then all of a sudden it doesn't work anymore, and then they have to switch to another kind of drug. So will you be pain-free? I can't guarantee that. Will it help? I would like to think that it would. That's the purpose of the drug. Will that be the exact right treatment for you? We don't know. Treating neuropathic pain is unique to every single person. The way we measure pain is very subjective. We ask you, how does your pain feel on a scale of 1 to 10? Well, some people are very stoic and they'll say, well, my pain's about a 2. Other people will say, well, I better say this pain's a 10 or I won't get the good medicine. It has nothing to do with that. If you have nerve pain, you need to be treated for it, but you need to kind of figure out where on the scale you are. So if some people might have a 5 and that might be really bothersome to them, some people will be at a 5 and it's really not such a problem for them. So it's very, very subjective. And that's why it's so very hard. Pain, the source of pain comes from all different venues in the body, and it's just very difficult to treat. It's really a trial effort to figure out what the right combination. Sometimes it's combinations of medications. Some people respond well to alternative treatments like acupuncture or hypnosis or relaxation exercises. Some people already have their mind set against that, and that's not going to work. Well, if you think it's not going to work, it's not going to work. But some people are very open to these things, and they get a lot of relief from alternative treatments. Some people take medication and do alternative treatments. So it's finding just the right combination for you, and it takes a long time, unfortunately, to say, but that is the way that all of that works. So I hope, and I wish you very well, I'm hoping that this will be just the change in medication that you need. The next person has a C6-7, and they're 15 years post from a motor vehicle accident. So they're thinking about tendon transfer surgeries. Would some finger extension return? Well, if you're having surgery to restore finger extension, you should have some return. It's not return of original function. What you'll do is have a tendon move from one place to another place. So you have some tendons that work well, and then you have some tendons that probably aren't working so well. So our body is very redundant in the way that we do things. Pardon me. So they'll take a tendon that's working very well. They might split it. They might use the whole tendon and move it to another spot. And then with therapy, you'll learn how to move that tendon so that it becomes natural to you. Because, your brain is telling the tendon what to do in the location where it currently is. If you have it moved to another spot, you have to teach your brain to tell the tendon now to move this other spot and make this other function. So if you have, if you're having tendon transfer surgery for finger extension, then you should have some return. It will take some work to get that done. Now, the big question here, is it worth the risk of such an invasive procedure? And that is a determination that you have to make. So be sure and talk to your healthcare professional. With any surgery, you have the risk of bleeding, infection, something, going wrong, something an error of some kind occurred, or maybe the tendon that you're having transferred, they test them to make sure that they work before you have the surgery and during the surgery, and then after they've tested it in the surgery, they test to make sure that tendon is working. So it's not like you have it and then let's see what came out of it. They know that it's working when they put it there. Making sure that it attaches correctly and all those sort of things. So that's for any kind of surgery, any tendon kind of surgery. And so they will be very cautious about this. You have to have a lot of follow-up therapy. You might need to have therapy before the surgery to bulk up the tendon and the muscles to make sure that they're ready to do that work once that tendon is moved to a different spot. So it's usually fairly successful surgery. It will not be like your hands worked before your accident. It will be an intermediary step. So, sometimes people have an image that, oh, my hand will work like it worked before. It will be different. You'll still have some limited function, but you'll have more function than you had before the surgery. And is it possible to talk to patients that have had it done? It certainly is possible. You should talk to the surgeon who's going to be doing the surgery. He's probably done it to the surgery to other people. So that would be... he would probably have a case list of people. If you want some people just in general talking about the surgery, you can certainly go on the communities on the Reeve website, and I'm sure that there will be people there that will be more than happy to tell you what their experience has been, good and bad. So that's certainly a possibility. Now, something to think about at the C6-7 level is to think about you'll be having in surgery, you'll be put on a ventilator for breathing. And so at C6-7, you should be able to come off the ventilator. You might be a little bit slower to come off than other people. You certainly have breathing capacity. You've had it before. You have it now, and you will have it then. But it might be a little more challenging to get off the ventilator. And then again, maybe not, because we don't know anything about you or your physical health. But sometimes people who have higher level injuries are a little slower. And that can be, by a few minutes. It can be by a few hours. Or it might be like taking an extra day. Or maybe you get off the ventilator, but you need some positive pressure breathing or CPAP or something while you regain your breathing skills. So talk to your surgeon and your anesthesiologist about how your return of breathing function will be. And probably they'll say, it'll be fine, don't worry about it, but just talk to them so that you're really comfortable and you know that what you as an individual, your personal risk on that would be. The next question is, what can I do to relieve severe pain, a bursitis in my hip from a serious fall? Pain pills aren't helping anymore. Well, you might want to talk to your doctor, because if it's been a long time and the pain is not resolving, sometimes people have a fracture, but it's a hairline fracture and it doesn't show up in the first round of x-rays. So sometimes you need to have an x-ray a couple of months later, and it might even be, even up to a year later if you have a spinal cord injury and you're not putting weight on those bones. That hairline fracture might not show up for quite a long time, but it will show up eventually. So check to see, make sure that there's not a fracture if you haven't had any x-rays of your hip in several months. Talk about, could there be a hairline fracture in there that maybe wasn't on the original x-ray. For bursitis, you've been taking some pain pills. A bursitis is, anything with an itis is an inflammation, and this is of the bursa, so around the hip. Sometimes they will give an injection to the area that will help take care of that. Sometimes you might need some long-term medication, not pain pills, but something more for like an arthritis kind of thing. So making sure you're on the right type of pain pills. Now, this is probably not for you because you've had this fall, you have this bursitis, so you know what the source of your trouble is. But I just want to bring this up for other people that will be listening, in that sometimes we have people come to the clinic and they are having pain hither and yon in their body, and they don't seem to be able to find any reason for it. And I always stop and ask the person, they're going through all these tests, I always stop and ask them, how old is your mattress? And they'll kind of look at me and be like, hey, that's crazy. And I'm like, well, if it's pretty old, think about getting a new one. The next time they come back, my pain is better. I got a new mattress. And it's like, So, again, looking at your equipment is very important. If you have a bed overlay that's been on that bed and you've been using it faithfully, it's given you good service for 10 years, it might be time to get a new one. Maybe it's not as solid as it used to be, or maybe it has a little leak in it, or sometimes when you have things that are made out of different materials, sometimes those man-made materials become weakened over time. Sometimes it is just the mattress itself not providing enough support. So I just say for everybody, check your equipment and make sure it's up to date, that it's functioning well. Now, just because it's old doesn't mean it's no good, but make sure that it's working up to speed as it should be. When you go in, and just annually ask for your healthcare provider to check your equipment. They might refer you to a physical therapist or occupational therapist to check the equipment, or you can even talk to the sales representative. Sometimes in clinics they'll have people there for ordering particular supplies depending on what kind of clinic you're in, and they can look at your equipment and make sure it's working up, making sure it's holding the pressure and that everything is working as it should be, that your body hasn't changed in some way. Especially after a fall, that could certainly be a change in the way that your body is aligned, or not that anything's really out of place, but it's just kind of shifted maybe a little bit. So there's a couple of questions you can chase down and see if that will help. And so it just sounds like if you've been on pain pills for a long time, it sounds like maybe you need to go to the next level for the bursitis. Or maybe your healthcare professional is going to say, well, it's just, it's going to take another month before you feel better. Sometimes with these orthopedic injuries, it might take like 6 months for something like this to resolve. So just hold on. Maybe you want to ask, if you've been going to a regular physician, maybe you want to ask for a spinal or orthopedic consult to look at that hip and X-ray as well. Getting a second opinion never hurts anybody. The next question is, could you discuss the importance of drinking water or cranberry juice versus soda in regard to the SCI? Well, when you have a spinal cord injury, you are emptying your bladder manually, so fluid urine is staying in your bladder for an extended period of time. So sometimes people who do not have a spinal cord injury, sometimes they'll drink something and is just within a matter of, if they drink a glass of water or something, just in a matter of like 10 minutes, I'll have to go to the bathroom, because it just seems like it's just rushed right through your body. And different fluids go through your body differently. When you have a spinal cord injury, you're cathing more on a time schedule. So usually there's a minimum of 4 hours in between catheterizations, and that bladder is holding that urine, and it's just sitting there, and it's stagnant in your bladder. When you're up moving around and you're walking, your leg muscles are moving, which are connected to your abdominal muscles, which are moving, which is shaking that bladder. And just moving your body is going to shake that urine up in the bladder. So when you do a pressure release, you're moving your body, which is affecting the urine moving around in your bladder. When you roll from side to side, when you're just pushing along in your wheelchair, your bladder's staying pretty still. Your body's moving, but it's moving, the chair's moving, not your body. Your body's just moving in the chair. So it's not shaking up your bladder. When your bladder's not shaken up, that urine's stagnant in your bladder, and if there's a little piece of bacteria in there, it will glom on to other pieces of bacteria and multiply, and it multiplies pretty quickly, and that's how you get a urinary tract infection. Now, there are some things that bacteria love to live on, and that is sugar. So when you get some sugar in your bladder and you have some bacteria in there, it's looking to survive. It's going to go for those sugar molecules and take those in, because that makes the bacteria really grow really fast. Both cranberry juice and soda have a lot of sugar in them. You can get cranberry juice that has less sugar, but it's still fruit juice. There's still some sugar in it. That's why water has nothing in it. That's why it's the best thing to drink. Cranberry juice, sugars, even diet sodas have saccharin in it. That works just as well for bacteria as sugar. Or aspartame, that works just as well as sugar for bacteria. Sports drinks, they all have a lot of sugar in them. Those drinks that replace your electrolytes, full of sugar. That's what gives you one of that little rush of contentment, I guess. The other thing is that these have a lot of caffeine in them. Soda has a lot of caffeine in it. So, and sports drinks have a lot of caffeine. So that makes you dehydrate your body as well. So water is the best thing to drink. Now, we're not all Puritans. We don't just drink water all the time. We all enjoy a cup of coffee in the morning, or some of us enjoy our iced tea. Some people like hot tea. There are all kinds of things that people drink. Alcohol is another. It is loaded with sugar, and also dehydrates your body. So water is the best thing, because it's a balanced solution that's not going to affect your body in any way except to fill up your bladder. So water is the best, but if you want to have drinks of other things, just drink in small amounts in moderation so that you're not harming yourself. Now, cranberry juice and apple juice have been ones that in the past have been ones that people said, well, drink that because it will keep your urine more acidic. And things that you would think like orange juice, it makes your urine more alkaline. So the less acid that's in your urine, the more bacteria proliferate. So they die with an acidic urine. And orange juice, although it goes in as an acid, it comes out as an alkaline substance through your urine. So it used to be that people would say drinking cranberry juice and drinking apple juice will affect the acidity of your bladder and therefore reduce urinary tract infections. But they've tested this scientifically, and they found out that this is not true. It's probably not the cranberry juice or the apple juice. It's just the fact that you're drinking some fluid that's flushing out your bladder. But it's also leaving behind some of those sugar molecules. So the best thing is water, but if you do want to drink something else, it's perfectly fine. Just do it in moderation. There's another question here, and it's about a person who is a C6 incomplete quad and injured for 6 years. He was able to move some of his toes in both feet, but a couple of months ago, after I received a Chinese massage, the movement in one of them stopped. Is this normal? Well, okay, no, this is not normal. If you had the movement, you should still have the movement. Is it related to the massage? Well, that really is unknown. Massages are one of those things that is kind of tricky. Some people do massages and they do it really deep, and it can affect the functions of your muscles. And some people will do massage, and if they do it real aggressively in your legs, if you have some blood clots down there, it can release the blood clots to your heart. After a spinal cord injury, and in this day and age, you should have some stabilization of your spine so that it should not be affected by massage. But since some people are real aggressive with the massage, and so you just never know when you get a massage exactly what's going on. Nobody does if you have a spinal cord injury or if you don't. So sometimes people, they get a muscle that really hurts after a massage, and they have to just wait for a while. It could have, just been too aggressively done. But anyway, so it's best to go right to your doctor and check if you have movement and anything happens that movement has gone away. You need to go to your doctor and have it checked. It could be just coincidental that it happened with the massage, or it could be because of the massage, but it's probably more coincidental. But you shouldn't be losing function. If you're losing function, it could be because you've had some kind of injury to the skeletal cage that holds the spinal cord. You cannot massage the spinal cord because it's inside the vertebrae, so that's not going to be, but you could move maybe one of the vertebrae if something had happened and it wasn't too stable. Maybe it could be pinching up against something, or it could be something altogether different that just happened to coincide about the same time as the massage. So sometimes people get what they call a syrinx inside their spinal cord after they've had a spinal cord injury. So when you have a spinal cord injury, no matter where it occurs, or actually to the spinal cord, a little hole forms in the center of the spinal cord. And sometimes that it just fills with fluid. And then sometimes that little hole can get bigger, and it's called a syrinx. And so you need to check to see if you have one, because if that continues to grow, you continue to lose more function. So you need to have that checked out and just make sure. So anytime you lose any function at all, you need to talk to your healthcare professional about that pretty pronto. Shouldn't be losing more function after your spinal cord injury has stabilized. Okay, next person has chronic hip pain and they can't find anything structurally wrong. He's been laying on his stomach for 2 years. Have you ever heard of anything like this? I have muscle spasms that cause it to hurt for sure. So something is going on that's making this chronic hip pain. And so the best thing is to check with an orthopedic doctor to see if there's some kind of problem that's going on there. We don't have a lot to go on here. It says they haven't found anything structurally wrong. It could be perhaps movement, or it could be some, if you're having some muscle spasms, it could be some cramping that's causing the pain, the hip to be painful. It might but not be bony. It might not be orthopedic. It might be a muscle problem that's causing that. So if the cramps are so severe, that could lead to hip pain because those muscles aren't relaxing. So we need to track that down a little bit more and see if it's a metabolic problem, or to see if it's an orthopedic problem that just hasn't quite shown up yet. But start with the muscle cramp instead of going with the chronic hip pain, because the way that this question is written, it sounds like it's more the problem is the muscle cramping that therefore is causing the hip pain. So you're not going to find anything wrong with the hip because the problem's in the muscle. Now, maybe it's just the way I'm reading the question, but I would go with that route and the things. Another question about a person having decompression at T6, 2.5 years ago. They live in a nursing home, not enjoying that too much. They have diabetes, hypertension, overweight, incontinent of bowel and bladder, and they're considering bariatric surgery. What are your thoughts? Well, again, first of all, think about all the risks that go along with surgery. Now, you're at T9, 6'9", so you're a lot lower of injury, so you shouldn't have as much challenges with the ventilation. But, all the risks are still go with it. Your body will still respond to the surgery. So even though at T6, that's below the level of that's like 4 finger widths below your belly button. No, that's 4 finger widths above your belly button. T10 is the belly button, so 4 fingers. So if they do this, they usually do these surgeries laparoscopically. So it will be in an area where you do have sensation. You need to get that card about autonomic dysreflexia, because my guess is you probably don't have symptoms of that, but you could have autonomic dysreflexia after the surgery. And since you've not been experienced with that, you might not know what to look for. So be sure you have that and alert your surgeon to that. People who have the bariatric surgery, there's different kinds of procedures that you can have done. People do lose weight. After about a year, people tend to put some weight back on, but not all of the weight. So think about that. At your weight, you probably will not be, in the BMI category of where you should be. It probably won't. You only lose a certain percentage of the weight, and so you probably still will be a little overweight, but not as much. But it certainly will help your hypertension. It certainly will help your diabetes. It may or may not make those two problems go away. In people without spinal cord injury, oftentimes those two problems get resolved. For you, they might not, because of the lack of movement in your legs. You might still, but you'll be definitely on less medication for those things. You'll be at less risk for other complications. So it all depends on if you want to take the risk of the surgery or not. I think perhaps you've already made up your mind about it and you're just kind of feeling it out, but it certainly is helpful for people to help their general body condition. It certainly would help you to be able to move around more, to be able to lift your own body, transfer yourself, and so it would give you a lot more independence, probably even be able to catheterize. It might be difficult now just due to size, and to catheterize and do your own bowel program. And so it might even change your living situation. So there's a lot of pluses here. The negatives are, of course, all the negatives of surgery. So those are some things to think about and, consider. It's an interesting proposition. So the next person is that they have foot drop. I've read about KT tape and wondered if it would help. I also have a symptom called contracture where my toes put up while I'm sleeping and go back down with standing or walking. So I've never heard of that called a contracture. It sounds more like a spasm. Contractures usually freeze the body in one particular position. There is reflex called the Babinski reflex in feet, and when toes flare out like that in adults, that's an abnormal response, which means there's some neurological problem there, so in the spine. So you might want to have that checked into a little more carefully. As far as the tape, you see a lot of people in the Olympics that wear that tape, and so a lot of people think, oh wow, that must be something. Now, and I've not talked to any of the trainers or physicians for Olympic athletes, but I have talked to physical therapists. And what do you think about those tape? They're colorful. On the Olympians, there is colorful tape, and the color relates to how much tension is in the tape or something. That it's color coded by some kind of key. I don't know what it is, but that's why they're all the different colors. And so the physical therapists that I talk to say, well, when you put tape on the skin, that only affects the tape. That doesn't affect the muscles underneath. And if you think about it logically, you can't put tape on your skin. If you put tape on your skin, it will, when you start to move, you'll get that sensation from your skin, and you'll think, oh, don't move so far, which helps stop your muscles from moving so far. So it kind of gives you a mental clue not to move your muscles, but it really doesn't keep the muscles in place, is what I am told. So would that help foot drop? I don't think that the tape would help the foot drop. Foot drop is when your foot doesn't extend up so that you can pick up your toes and do the normal walking gait. It just, your toes tend to just drop right down, and you can't pull them up. There are some, usually for foot drops, there's splints that people wear. People hate them. They're hot. They're, hard to fit shoes around them, and they they can rub on your feet. There's some devices that you can buy online, which is like a little cuff that goes around your foot and a little cuff that goes around your ankle, and then there's a connector that holds your foot up. It's a lot more comfortable. It's a lot easier to use, and that will definitely support your foot and hold it up. It's a lot easier to get these little cuffs in shoes. You don't have the awkwardness of the appliance going all the way up the back of your leg. It's not hot. It's more comfortable. Sometimes you can take a little cuff around the ankle, and if you're wearing tennis shoes, you can just attach the other end to the laces of the farthest away on your tennis shoe, and that will also support your foot. So that's, I think, one of the best things you can do for foot drop. So that brings us to the top of the hour, and with that, I'll sign off. But be sure and look for us on the community. I'll be on there tonight. So if you have any questions, be sure and write in. Thanks so much. Bye.